I was asked to talk on multidisciplinary pain management. And since that's something I love dearly, you're probably going to hear more about multidisciplinary pain management than you ever really wanted to hear. But that's the price you pay for being at the meeting. Now, if I can figure out what makes it go forward. My disclosure, I have no outside funding at the present time, but you should know that there once was a destroyer with my family name. It got scuttled after World War II, but I'm still hoping there'll be a Navy. Multidisciplinary pain clinics were born in the 1950s and 60s. They clearly, in our country, have passed their high point in terms of their numbers, and they were certainly a novel concept for the delivery of health care. Hopefully, as we have more and more evidence-based medicine and outcomes become more and more important, there will be a resurgence of multidisciplinary pain management. And perhaps the realization that chronic pain is usually a brain disease and is not due to something wrong in the periphery may lead to a change in what we do to treat chronic pain patients. Now, as far as I can tell, the first organized groups to treat people with pain evolved in the late 19th century. Now, you need to know that anesthesiologists were not behind these organizations because there weren't any anesthesiologists in the late 19th century. It was the surgeons who were involved in trying to do something about pain. And the first one in the United States was a guy by the name of Rovenstein at New York University who established a nerve block clinic staffed only by anesthesiologists, providing no services beyond nerve blocks for people with pain. That was the first in our country. There were multidisciplinary clinics established very early on by a Dr. Alexander in Texas and by Dr. Livingston in Portland in the 50s. Neither of these had any longevity, but they were present for a while, and Livingston was a very important figure in the development of thinking about pain. John Bonica was the primary force in the development of multidisciplinary pain clinics. He established the first multidisciplinary pain clinic in Tacoma when he was discharged from the Army after World War II. He had been at Madigan. His pain clinic was staffed by different medical specialists and nurses and involved a team approach to trying to treat pain patients. The pain movement was launched when Bonica was appointed the first professor and chairman of anesthesiology at the University of Washington in 1960. At that point, he developed a platform from which he could lead this whole thing. He was not completely unique. There were other pain clinics in the early era, City of Hope. There was one in Sydney, Australia. There was one in Oxford. There was one in Jerusalem of anesthesiology-based people who thought that they should do something different for pain. So the beginnings of the path to multidisciplinary pain clinics, 1960, Bonica came to the UW. In 1961, a psychologist, Bill Fordyce, joined the rehab medicine department at the UW and started participating in the pain clinic. In 1965, Fordyce, who was the pioneer of behavioral medicine, started what he called the operant therapy program for chronic pain patients that were referred from the pain clinic. His book, Behavioral Methods for Chronic Pain and Illness, completely opened up a new avenue of treatment for both chronic pain and other chronic illnesses. And in 1983, Bill Fordyce and I were given a whole ward at the university hospital to set up an inpatient and outpatient multidisciplinary pain management clinic. Fordyce was clearly the pioneer in applying behavioral medicine to pain. He did early observations on the role of social reinforcers in pain behaviors. In the preface to his book, this book results in part from two different sets of observations or developments. One stems from the obvious shortcomings of traditional healthcare approaches for resolving adequately many problems of chronic pain. The second is the emergence of behavioral methods and concepts as important evaluation and treatment tools for a variety of human problems. This was a revolutionary book. What we created in 1983 was a service that consisted of one wing of the university hospital, both inpatient and outpatient space, including a nerve block room. It was a single administrative structure independent of the departments that contributed faculty. All of our faculty were full-time in the pain clinic, and we created what was called a structured program, which was the centerpiece of our treatment options. It was the beginning of an important movement where the biopsychosocial concept of disease displaced the biomedical approach. But unfortunately, even today, there are vast numbers of physicians who still are relating completely to a biomedical approach that does not include the fact that human beings are social animals. A caveat: there is no patent on the word pain clinic. My favorite example of that is when I was going with my wife to visit her birthplace hometown of Boise, Idaho, and on the main street there was a huge billboard that said pain clinic. In the bottom of it, it was Joe Doe chiropractor. So one chiropractor called himself a pain clinic. That happens all over. You need to be very careful thinking about pain clinics as to what lies behind the sign, because there is no standard or requirement as to what is a pain clinic. Now, the other thing that I'm going to hit, which is part of, I think, the reason why I'm willing to talk about multidisciplinary pain clinic, is that in spite of the fact that the best outcomes evidence for the treatment of chronic pain patients lies with multidisciplinary pain clinics, it is commonly the case that governmental agencies, third-party payers, and many unknowing physicians deny the efficacy of multidisciplinary pain treatment in spite of overwhelmingly positive evidence that it's better than anything else we have for chronic pain, and certainly better than what we've found out about opioids. So let me look into with you what multidisciplinary pain clinics, in my opinion, really should consist of. First of all, the realization that chronic pain is usually a psychological and environmental disorder that is rarely amenable to biologically based fixing, especially by the time of referral to a multidisciplinary pain center, where the data shows that the average patient has had chronic pain for 3 to 5 years before being referred to a pain center. What do we know about chronic pain patients? Well, the duration of their pain has far exceeded healing time from whatever potential injury they might have had. The diagnosis does not explain the pain. In fact, to be very honest, the diagnosis a patient carries tells me what kind of doctor the patient has seen. It doesn't tell me anything about what's wrong with the patient. Chronic pain patients consume excessive amounts of health care. They have much more disability than you would predict from your physical findings, and all too often they have lost control over their life events. They're frequently depressed. They often use medications inappropriately. They are physically deactivated. They manifest high levels of anger and frustration. They usually have a collection of healthcare providers behind them, and they are totally fixated on the idea that if you could just fix this one broken spot in my back, doctor, I'd be perfectly normal again. There are often many prior pain complaints. Social stressors are common. Environmental reinforcers are common. They deny the role of psychological factors, and they have this interesting belief in it's just this little broken part that I have that would be fixed and I will be better. So the goals of multidisciplinary pain management: to reduce the self-report of pain. You'll note that I didn't say to reduce pain, because you don't have any idea what's going on inside another person. You can reduce what they tell you about their pain, but what you're doing to their pain, you don't know, and neither do they. You can improve people's physical condition. You can improve their psychological well-being. You can manage medications appropriately. You can identify and pursue vocational goals. You can treat depression, and you can educate people about how their bodies work and what health care can do for them or to them. Now, like any other kind of treatment, multidisciplinary pain management requires screening patients to identify those who are the appropriate candidates for this type of treatment. Coercive treatment never works. It was the kiss of death when labor and industry said to a patient, "You are going to the pain clinic or we will stop your benefits." You don't get those people better. People must have what we identified as treatable causative factors, such as depression, deactivation. They need to have a stable general medical condition, because you can't physically rehabilitate people who are so impaired by their cardiac disease that they can't walk. They need to have inappropriate medication usage, so you can correct that. And they often have the craziest beliefs about their bodies, and you can help people significantly by educating them. So the desired outcome is changing the patient's behavior. It's a much broader concept than treating illness itself. What you're trying to do is get people back up to freeway speed. Reducing their pain is part of it, but it is not adequate. The idea was to treat pain behaviors, because you cannot measure pain itself. There is no tank into which you can put a dipstick to measure pain. We treated people in a group. Exact group size isn't important. We usually were running between 10 and 14 patients. The advantage of a group in the treatment idea is that it's much cheaper to manage patients in a group. It is amazing how beneficial peer group support can be to patients. And by rolling the admissions to the group, you can have neophytes being assisted by veterans as they come into the program. And that was an important feature. What does multidisciplinary mean? Again, there's no patent on the word. For us, it meant physicians, psychologists, nurses, physical therapists, occupational therapists, social worker, vocational counselor, non-professional staff, and sometimes even others. The idea being that different educational backgrounds bring different skills to bear on rehabilitating the patient. One important issue is all the members of the treatment team must agree on the goals and methods of reaching them. You cannot have physicians arguing with psychologists about what to do when you're trying to run a program such as this. We aimed at increasing function. Increasing function in a program like this meant meeting their physical therapy and occupational therapy quotas, and I'll come back to that, eliminating medication dependence, learning relaxation and coping skills, decreasing pain behaviors, socializing appropriately with patients and staff, and engaging in all aspects of the program. This was not a menu from which people could select the things they wanted to do. This was a package, and you were either in it or you were not in it. Opioid management. What an interesting thing to do with. Back in the 80s and 90s when we were doing this, almost all the patients we were referred were taking opioids as well as other things, including a lot of benzodiazepines. Most of them were seeing multiple doctors, getting their prescriptions from doctors who did not know that there were other doctors also prescribing. We have solved that problem today with our prescription monitoring problem, but before that was implemented, it was a big deal. All these patients complained of pain and had disabilities precluding a normal lifestyle. Most of them were depressed and had poor sleep patterns. And these were the issues that we tried to deal with. When it came to the opioids, the patient had to agree that the drugs they were taking were not solving their problem. If they were, why would they be coming to the pain clinic? Sometimes people had a hard time understanding that, but we worked hard on it. We developed a strategy which was labeled the pain cocktail strategy, which was fully explained to the patient. The idea was we took note of all of the drugs they were taking. We converted all of the opioids to methadone in an equivalent dose, and then put the methadone in a cherry syrup vehicle so that we could reduce the amount of drug in their pain cocktail as the days went by. And they did not have the ability to tell how much drug was in the cocktail. But we told people that the goal was to get you off of all opioids, and it was a 21-day program, and we wanted people off of their opioids a couple of days before they left. So basically, we tapered people from whatever they were taking to zero in 19 days. We never saw the doses that are floating around now. We used to think that 20 or 30 milligrams of morphine a day was a big dose. Whether this strategy would work with somebody taking thousands of milligrams of morphine equivalents a day is not at all clear to me. In fact, if I were to try and do that, I think I'd try and taper the opioid down to reasonable levels before they got into the program. But we never saw the kinds of opioid dosing that are commonly seen today. So the opioid management strategy fully explained to the patient there was no deceit at any time. It was clearly successful in the short term. We do not have long-term data on recidivism. We know what happened about 3 to 6 months out, and they stayed off the drugs for that period of time. But what happened down the road, we don't know. We were able to show that their pain decreased and their activities increased as the drug dose decreased. We didn't have the megadoses common today. We don't know if it'll work with megadoses. But this is what happened over a 21-day period. The activity in the red line went up dramatically, all sorts of physical activities, including time, speed laps, and other exercises. We asked them what their pain level was daily, and we measured their drug dose. And so in contrast to what you might expect, decreasing the opioids was associated with increased activity and decreasing pain. We had a variety of group sessions in such a treatment program. You can put them into 3 broad groups: educational, skills training, and implementation. Here's a list of the educational topics that we talked to the patients about. Many of the patients were able to learn a lot about how the human body worked. They understood what the gate theory meant. They had a much better idea of what surgery could or could not do for them. And it was very rewarding as a teacher and as a physician. Remember, doctor is derived from the word to teach. To have patients obviously learn a lot about how their bodies worked and what healthcare was all about. Critical single issue, if I had to pick one issue for a chronic pain patient, it's hurt and harm are not synonyms. There is no evidence that moving around, even though it hurts you, is harming you in some way. That is the big hurdle to get across with chronic pain patients. Hurt and harm are not the same. We also taught them skills that would help them deal with the stresses of life. These were literally little mini classes that were taught either in groups or sometimes individually as needed by the patient. And we had groups where we implemented the things they'd learned, where they actually practiced things like planning times and identifying gains and how to use the educational materials. People came from all over the world looking for our magic because this kind of treatment was thought to be magical. And it interested me because I thought all of our healthcare providers were great, but the magic lay in the communication between providers. That was the glue that kept this program together and kept the patients on target. Summarizing a huge number of studies, 60% of the patients returned to work and remained at work 1 to 2 years after their treatment. Physical activities increased by 300%. Inappropriate medications were decreased 55%. Half the patients stopped seeking health care for their chronic pain, and their pain ratings, that is, asking them what their pain level was, decreased by 35% for at least a year. So again, the focus was not on what your pain level was. The focus was what could you do? What was your functional status? And this is from a paper by Turk and Okifuji relating a cost-effective measure of multidisciplinary pain management versus routine conservative care versus surgery for back pain patients. And this is the kind of stuff that the literature is full of, showing that multidisciplinary pain management is better than other treatment strategies. The Cochrane database did a systematic review and said there was strong evidence in intensive multidisciplinary biopsychosocial rehabilitation with functional restoration, which is what we were doing, improved pain and function when compared with inpatient or outpatient non-multidisciplinary treatments. So in my viewpoint, multidisciplinary pain management was and still is the best available treatment for properly selected chronic pain patients. Symptom relief and functional improvement must be the goals of treating chronic pain patients. Unlike acute pain, where you are addressing their pain while nature cures the problem, as Voltaire said, nature cures and doctors get the credit. In acute pain, nature is going to heal the problem, and you provide short-term pain relief and can facilitate nature's healing by sewing up a laceration or immobilizing a fracture. Chronic pain, you have to address the functional impairment or you're not going to resolve the problem. Successful therapies for chronic pain patients require active patient participation. Most patients think that all they have to do is walk in the doctor's office, lie down on the table, and the doctor's going to cure them. That does not work for chronic pain. You've got to get the patient up to freeway speed. Of all the approaches to the treatment of chronic pain, none has a stronger evidence base for efficacy, cost effectiveness, and lack of iatrogenic complications than interdisciplinary care. This article by Michael Shatman. So, I think the individual practitioner should be more than a monodisciplinary provider and should listen to the patient's story and some of the strategies that were evolved in multidisciplinary care management can be applied to primary care management. Perhaps not the whole program, but at least components of it. Chronic pain is a disease of the brain. It is not a disease of the part of the body that hurts. Indeed, somebody who's lost a limb can complain bitterly of chronic pain in the absent limb, and I don't think you're going to accept the fact that the limb is the cause of the pain. So, brain disease can be addressed by psychological, physical, and environmental therapies, and sometimes by drugs and procedures. But most of the time, the ideal treatment strategy for chronic pain patients is multidisciplinary pain management. And I think that's the end. Thank you.